My name is Holly Gleason, and I work in marketing and business development at Futures Recovery Healthcare. This is our 8th free virtual CEU event that we are able to offer to our professional community, and we're so excited to continue doing so. On behalf of Futures and our co-sponsor Bayside CEUs, I just wanted to thank you all for joining us today. With that, I'm going to introduce my colleague, Brandon Hamdorf, Outreach Professional. He will be assisting me with the virtual tour, and he will then introduce our amazing speakers for today.
Thank you very much, Holly, for that introduction. I appreciate it. I'm very excited to see you all here today. For those of you that don't know me, again, my name is Brandon Hamdorf. I'm an outreach professional down here at Futures Recovery Healthcare in Tequesta, Florida. And as you can see from the start of the beautiful photos, Futures is a family-owned residential treatment program located down in Tequesta, Florida. In total, we have the capacity to help about 105 patients in total. We do offer comprehensive detox and residential programming for adults struggling with substance use disorder, co-occurring disorder, and also primary mental health needs. We've been open now for about 9 years, and as you can see, it's a very beautiful and serene campus located on about 9.5 acres in total of gated property. One thing I can say about Futures is that we're extremely passionate about the programs, tracks, and services that we offer. You're probably familiar with some of them, but our main programs are named CORE, RISE, Orenda, and we also have a primary mental health program. In addition, we offer specialty tracks for chronic pain, first responders, and folks who struggle with trauma. We're now going to go ahead and take you inside our campus and walk you through the facility. Now you'll notice as you enter Futures, you'll be met by a member of our team, and our goal is to make folks feel welcome and at home from the first time they enter our doors. Our alumni program, which is called Days of Ascent, that main office is located right up front and also provides additional support and also explores alumni services with each and every one of our patients. I do want to pause for a quick second and say that the most breathtaking part of this tour focuses on our Ascent statue. So this statue was commissioned by an artist by the name of Gary Lee Prince. And I had to make sure I had it correctly, but there was a brief excerpt from Gary's description of the Ascent statue. And I just wanted to share that with you guys this morning. And it reads, "This sculpture epitomizes the struggle to overcome opposition and difficult personal challenges and the absolute need that we have for others to reach out, bring us in, and raise us up." Like, how beautiful is that? My favorite part of the tour. On the other side of the statue, we have a beautiful courtyard entrance view that we're going to show you. And this is a very relaxed space for our patients to occupy throughout the days and evenings. It's also a really fun spot for our musically inclined patients to show off some of their skills, whether that's on the piano, playing guitar, or drum skills. And trust me, for our musically inclined folks, they definitely love to show off their skills. The next stop on the tour, if you were here with us, we'd head down the hall to the right, and you're going to see our dining area. So the dining area pictured here hosts our CORE, RISE, and mental health program patients' meals. Each patient does have the ability to select their own choice of lunch and dinner for the entire week, and they get to enjoy a beautiful continental breakfast style option each morning. I will like to add that our culinary team is exceptionally skilled, and we do a very good job of accommodating all food allergies. And we can get a little creative as well and use certain ingredients to help offset some early withdrawal symptoms and even inflammation. Next on the tour, we'd head down the hall to the left, and I do want to add that we would be passing one of our 3 nursing stations. So we do have 24/7 nursing. We have 3 nursing stations, 1 on each floor. Our medical director, Dr. Gloria Duncan, along with our nurse practitioners and psych nurse practitioner, oversee all the medication management for each and every one of our patients here. Now, onto the rec area. I like this spot because who doesn't like to have fun in recovery? And I think the real question we get asked is like, how do I even have fun now that I'm in recovery? And that answer is yes, we can have fun in recovery. All you need to do is show up on a Thursday afternoon and watch a game of staff versus patients volleyball, and you'll realize that fun is truly possible. We also have a full-size tennis court, a half-size basketball court, and plenty of green grass for normal body weight movements like walking, running, push-ups, air squats, and much more. We're now going to head back inside really quick. We're going to stop at another favorite part of my tour. I guess I have a lot of favorites, but the fitness center is one of my favorites because we have a non-opioid based chronic pain track. So anyone coming to Futures and who is enrolled in the chronic pain track gets to work one-on-one with our in-house physical therapy team that is led by Dr. Ahmed Rishwan. And the nice thing about that track is that they also work in conjunction with our clinical and medical teams to help our patients reach their body's fullest potential and healthiest potential while they're detoxifying and going through those beginning stages into recovery. Next, we'll head outdoors. We'll show you the pool space. Our patients, once they're cleared from medical detox, they do have the ability to access all the amenities that you've been shown far. And the pool is just a great place, as we all know, when it gets really hot in Florida, just to kind of wind down at the end of a busy clinical day. On the other side of the pool, we have a koi pond. And I like to add that in addition to the chronic pain specialty track that I just mentioned, we also have specialized services for first responders and also for individuals that struggle with severe and significant trauma. EMDR, DBT, hypnotherapy, clinical art therapy, seeking safety curriculum, and much more are all really strong components of those additional specialty tracks. And what I like about the koi pond area is I've seen numerous patients just taking time out of their day, sitting down, watching the koi fish swim around and listening to the beautiful sounds of the mini waterfall. So it's a very relaxed space for our patients. All right, now we're gonna head upstairs. I did want to make sure that we took the time to show you one slide from our Orenda program here at Futures. Orenda essentially is our concierge program. It's designed to meet the needs of professionals that are committed to a more high demand occupation, or folks who are inextricably linked to public personas, and really those individuals that have a hard time to removing themselves from stressful situations and triggers that often, work out with addiction and dysfunction in their career paths. In Orenda, each one of our clients has a custom tailored treatment plan, and we focus on 4 pillars of care, which encompass wellness programming, neurorestorative care, neuropsychology and psychotherapy, and lastly, addiction medicine. So pictured here, you can see our Orenda private dining, which is located on the 3rd floor. And really our Orenda clients just appreciate an atmosphere in which they're accustomed to enjoying. The last 2 stops on our tour, we'd like to show you our bedroom and a bedroom living area. So first you'll see here is our core and mental health patients. They get to know that they can enjoy their own private bedroom and private bathroom. I think that's important. So they have their own space to kind of decompress after a very stressful day or stressful week. And the last slide we're going to show you is a bedroom living area. So pictured here is a private suite, which is a standard option for our Rise and Orenda clients. Now, should a core or mental health patient want a private room, they can speak with our team about that additional cost and clinical appropriateness. We want to make sure it's an appropriate discussion and decision. So that concludes our tour. You guys, there's so much more that we could discuss regarding Futures, but I really want to take some time right now to turn it over to our amazing presenters, Amy Effman and Dan Perzanowski, for the wonderful presentation they prepared for you all. So hope you enjoyed the tour, and without further ado, I'm going to turn it over to Amy and Dan. Thank you guys so much for being here today.
Folks, hopefully everybody's having a good morning. We're having wonderful Florida rain here, so hopefully you can hear us all well and we don't have any technical difficulties. I'm going to share my screen with you to start our lecture presentation. Do that.
I'm going to jump in, Dan, if I can. I
Please.
just wanted to first introduce myself. My name is Amy Effman. I'm a licensed marriage and family therapist, and I am one of the family therapists that works alongside Orenda's program, the executive program. And Dan works closely in all of the programs as a family counselor, working with all sorts of clients and their family members that come to treatment with the intention and goal for healing. And I think what's really important as we kind of go through this presentation is that we think about the mindset in which we are operating from, which is a little bit more postmodern than what might maybe families or clients think about fashion therapy, which is that it's linear and we're working with one person's problem set. You'll see kind of intertwined throughout the entire presentation that the intention is that we identify the entire family system as the IP or the identified patient, if you will, or a customer of change. So this is a pretty awesome and exciting topic for the two of us. We've both done a lot of family work over the years, and in our own experiences doing family work, it's interesting to see how things have transitioned within the industry and the way we practice what we do. So we're really grateful to be able to have this time and space to share with everybody. And I know Dan's going to set it off with our learning objectives, but I just wanted to say hello and just thank you all for your time. I know time is very difficult to come by, and just say how passionate we both are about this topic and what it means to help, the families of the person that actively shows up on our doorstep, motivated for change or sometimes not motivated for change. So we feel strongly that this is a really important topic, and we're grateful that you're here. So thank you.
So with that being said, they call me Dan the family man around this place. And I think that it's a good nickname. I've been doing family work and doing recovery work. As of September 9th, it'll be 30 years. And sometimes that's painful to even say, but it's been a wild ride. And so the things that we're doing in regards to family work are things that we wanted to throw out there today to talk about some of the nuances and changes. And I don't know about all of you, but for us, when we started to come back to doing in-person work after being stuck in this pandemic and doing a lot of Zoom work, a lot of things changed as far as my perspective on doing family work. I started to look at things based on looking at the family's fears and looking at what the healing process was going to be. So when we dive into our learning objectives, we talk about identifying and strategizing how to address the entire family system. I want you to think about fears that the family has and the healing process. So what we like to do is we like to look at the personal expectations that each family member has, whether those are real expectations or false expectations, and then setting the appropriate boundaries for each person's self-care. Now, self-care is something you're going to hear constantly in this presentation in regards to how the family system is going to come together. In AA, they talk about each person keeping their side of the street clean. And that's something that needs to happen within family work. So the psychoeducational information that we provide families in crisis is really individualized based upon their experience. So I want you to think of two other things as you think about the information that we give families. I want you to think about landscape, and I want you to think about language. And the reason I want you to think about those two things is that I'm a good New England son, and depending on where you're from in New England, there's a whole different language, there's a whole different culture. You could move from Massachusetts to Connecticut, and there's a completely different set of agendas, expectations, and boundaries. And that's what happens within family systems. So for each family system, we need to really take a look at where they're coming from. So we move into the 3 I's, which are to identify, implement, and integrate. And those are the ways that we start to individualize family work. We identify what are called the family's core issues. What are things that have been problematic, and how can we now implement new coping strategies to aid them and have them integrate that into their family plan? And then family with identified core stressors and dealing with an addictive loved one and how it impacts them. I know a lot of us over the years, and I'm sure if I ask for a raise of hands, we all know what an impact letter is. And an impact letter sometimes gets way off the tangent because there aren't any guidelines to how to write an impact letter. So one of the things that we've done is we've developed kind of a questionnaire in and around specifically dealing with the family's issues in and around their own core stressors, their fears, identifying those fears, and identifying things that they believe are going to be beneficial for them in regards to their healing. And that's going to be different between mom and dad, husband and wife, sister and brother. Each person needs to identify what those core stressors are so that we can start working on how we're going to bridge this family to get back to having open communication. The other two words you're going to hear constantly in this presentation are transparency and tolerance. because we think that's going to be one of the biggest things that families are going to benefit from, is having transparent conversation, but also being tolerant and hearing each other through. What we also want to look at is the steps required for a family to provide a healing environment. Now, one of the biggest things about a healing environment that I say to families, and Amy says to families every day, is we want you to think about a safe space and a safe place. Space and place, because a lot of times families will ask us, it's okay, what's going to change when Johnny comes home? Well, there has to be a lot of different changes, and it's not just about people, places, and things. It's about where the patient and the family feel comfortable in their physical environment, in the mental environment, and the emotional environment. So what we want to start looking at is what really is a healing environment. Working with families to explore those physical, mental, emotional, stable environments is getting them, for all of you therapists out there, you know the E over I and I over E. We have so many families that are hurting, especially after what changed my whole mindset was this pandemic made everybody in the world have issues with adjustment disorder and adjusting to how things went on. And these emotional based decisions that continue to happen. I know some of you out there have children in school, and these poor teachers and these poor students and the adjustments they're having to make every day to circumnavigate this world in the middle of this pandemic. And all of these emotionally based decisions, we have to help families get back to intellect over emotion, starting to make intellectual decisions rather than fear-based decisions. And how we're going to do that is having them truly look at the evidence. So another statement you're going to hear from me constantly today is as evidenced by. As evidenced by what? Do we need to start working on something? So when we look at identifying family recovery, and that's what I want people to think about, not just the identified patient, but family recovery. What is that going to encompass? And what does each person need to do for their role within the family recovery process? And then, of course, aiding family with seeing how family members' perspectives and beliefs impact within the family system. One of the things that we work on is the identified patient's toxic belief system that has kept them stuck in addiction or mental health or perseveration of thought. What we want to look at is what kind of belief systems and toxic belief systems have impacted the family. Where are they staying stuck? Where are they not moving forward towards healing? Through into the learning objectives, a game that I've played for years with families. I'm going to tell you what the rules of engagement are for this game. It's called the Family of Origin game. I wish I could play with all of you, and I usually, when I do this presentation in public, we do it in person. I did it with my colleagues yesterday, and they didn't like some of the rules to the game. The rules to the game is that every person needs to give me the year they were born, where they were in the pecking order, and what I mean by that is, were you the firstborn, were you the middle, or were you the baby, of how many, and what do you consider the place, culture, environment that you grew up in? Was it what state, hometown? Give me those perspectives, because if I could do that game with the 100 and so odd people that are out there right now, you'd find out the differences in just generational and cultural belief systems that are out there. The fun part of doing the Family of Origin game is that you can really start to see how where a person was and the space and place they were in impacts how the family operates. And then family will be able to walk through their fear and discover healthy ways of rebuilding. We've started family forums here again, live and in person and online. And in doing so, we're having the families start to identify the core fears and then start to explore the ways that they believe through their self-care, the whole family can heal. And then family work on establishing, of course, the ability to talk, trust, and feel. And for those therapists out there that have been in it as long as Amy and I have, you know who that's coming from. That's Dr. Claudia Black. I mean, the talk, trust, and feel is about getting the person to be able to become transparent, is the word I've been using constantly, to get them to be in the trusting relationship and then be able to be tolerant. So talk, trust, and feel. And then, of course, I have to end with transparency and tolerance. What we're looking for from each family member is to get to their level of transparency. to be able to start talking about the things that have not been talked about, to get out of those triangulations of communication that happen when a family is doing nothing but sitting in that fear. And that's why right now, whether there are families that are here at Futures or families out there, every family in America, every family right now in the world is sitting in fear of some form with this whole pandemic. So think about that. If we're sitting in that fear, what kind of decisions are we making in that fear-based world? And that's why, I just recently became a grandfather for the first time. I do not want my grandson living in this fear-based world. I want him to be able to live a life where there is a level of transparency and tolerance. And I know all of us out there want the same thing. So we're hoping to be able to give you some different perspectives, some different twists on family work today, to be able to look at some different nuances. I've been doing things, and Amy has as well, working with individual families where we encourage something called the family conversation. And that's based on transparency and tolerance. So I really appreciate you guys kind of tuning in and being a part of this process. And I told my colleagues today, the biggest thing that I'm looking forward to is your perspectives and hearing your questions. So when we think about summarizing where we are, we're trying to get to the point of identifying and understanding the characteristics of this fear, to examine the family response and caretaking, to identify how the patient and the family evaluates the impact on their roles and their coping behaviors. And then this course will be able to help with the definition and the further expansion of family recovery. And I've been out on LinkedIn over the past 2 months doing nothing but talking about family recovery. And I want family recovery to be at the forefront, because I believe that if we really define what family recovery is, we are going to be able to aid with reducing the stigma that our patients deal with every day and those families deal with every day.
Thank you so much, Dan. I think I'm going to jump in here and share a little bit about the perspective and the lens in which we operate from, and what we mean when we say family system. So everyone can see there's this baby mobile kind of hanging over the crib. And the intention when we start to work with families and treat families is that each family member, I think it goes actually beyond the family system or the nuclear family, if you will, the family we're born into. But I guess we should kind of back up and talk a little bit about what the definition of family is for any specific individual, client, customer of change, patient, whatever we choose to call person or individual. Who is their family? I know my experience working with Orenda and just working within treatment centers and working with various types of people from different cultures and different backgrounds. We need to be mindful that some people expand their family beyond just the people that live under their roof, or maybe the people that they hire to assist in creating that family system, nannies, assistants, physicians, therapists, psychiatrists. Oftentimes when we're meeting with people, we don't really know their definition of family until they can provide for us kind of a larger picture of who's most affected and who's impacted by their actions and behaviors and choices, and vice versa. So this is just kind of an illustration of a baby looking up in a crib, if you will, and seeing this baby mobile and remembering as a kid, if we had these things, I know I did, if we touch one side or one animal or one color, what tends to happen to the rest of the system? It gets a little bit wobbly. And oftentimes in systemic thinking, we're talking about homeostasis and how do we create a more stable, consistent, healthy environment for someone to heal in, specifically as we're talking about substance abuse and mental health. So this is something to be extremely mindful. I know in my practice, as I'm working with people, the first time I meet someone, I am extremely motivated to ask questions that would provide a family genogram or a family map. And I am less concerned immediately at hearing about the actual substance dependence, but more about the people they identify as being within their family system, and to learn about the relationships between those people. So here you'll see operating from a systemic family therapy lens. Again, it's a mindset, it's a style in which I think and operate and Dan operates and his team operate when working with an individual is that we see a larger picture, right? We are stepping away from what we used to call linear or traditional thinking, which might assume that if A, then B. So historically, years ago, if alcoholic, then assumption might be depression. These days, we know a lot different and a lot better, I should say. We need to ask questions and remain curious, which is a huge driving force for my practice and something I strongly, strongly advocate for when meeting with people. We cannot assume really anything based off of a physical presentation. Sometimes even a biopsychosocial only provides so much information, an intake, the referent, even the referring doctor, psychiatrist, therapist. Oftentimes we're getting pieces of information. But what we like to do as systemic family therapists is we like to request collateral information from both providers that have worked with past person, family members. I know Dan and I, when meeting with someone, typically within the first day or two of meeting with someone, we want collateral information from family. Dan had mentioned that he's now sending out family questionnaires and assessments to see how the family is responding and reacting and feeling. But we want to be mindful of the entire system and all of the factors that play into that. Here you'll see systems therapy recognizes that everything in our lives is interconnected. And I think the takeaway from this presentation is really thinking about who all is a part of the larger system when meeting with individual, even with meeting with couple or meeting with family. We want to be mindful, who are the other people that are impacting this person or this couple. And I know working with people that do not have substance abuse or mental health, similar process, if you will, asking several questions about nuclear family, the family in which we're born into. If there's a history of adoption, if there's a history of trauma, if there's any influence by the criminal court system or the divorce court system or Department of Children and Families, what are the other systems that are involved in someone's life? Okay, so if we looked at the family as an immune system, as Dan has mentioned several times, the intention or the goal is to offer services and to offer support to the entire system as individual, let's say, shows up on our doorstep in a treatment facility. We want to make sure that not only are we providing the proper treatment while somebody is in our care under our roof, but we want to make sure that the transition from the time that we work with them to the transition back to their quote unquote home, family, employment family, cultural family, religious family, recovery family, that system is a healthy one for people. And we see that very much like an immune system. So if someone is healing from whatever they're healing from, and they go to a hospital, a recovery, a treatment facility, a mental health facility, that is all very important in planting seeds. And we only have so much control over planting these seeds. But what is the next step, and who's going to be a part of that person's life when they skedaddle from their treatment or their healing environment? Is it going to be a healthy environment, or are they returning back to an abusive, high risk, very dangerous environment for their mental health or their well-being overall, or their self-esteem? What is the marriage? What do their relationships look like? What do their friendships look like? What is their relationship with their kids or their adult kids? So these are all things that we remain mindful of as treating an individual. We want to know, what is the immune system or the family system, the support system look like when they leave? And what if they don't have anybody they identify as their family system? How do we create that through the recovery community or through a healing community? Okay. So social constructionism is a lot of this information that I'm sharing, that basically, as we navigate life, the experiences and the people that we invite into our life from an early age kind of create what we perceive as our reality. Even just the definition of who's your family or who are you in a relationship with? What does a relationship even mean to a person? And how do people create their identity based off of social pressures and other things that are kind of coming into our existence and our mind? Oftentimes, as I'm working with people, specifically people struggling, I like to really challenge their perspective. specifically those in Arenda that have very fixed thinking at times, right? I'm extremely successful and productive at XYZ in my life. Perhaps I generate a great income. I am a powerhouse at work. I'm fantastic at XYZ, but something about this fantastic life you speak about has brought you to a place where you are seeking guidance or support for different core areas of your life. So I'm often curious, if someone is uber successful in business, might they also identify as, I've noted a couple quotes I've heard oftentimes, I'm a loser parent. Everybody leaves me because I'm not good enough. What do these other systems or relationships look like in people's lives? Even people who are performing high in one area might not necessarily be performing very high in the other. I'll never be as successful as my parents. I mean, oftentimes we see this pattern in treatment facilities. I know when working with young men and they have a very successful parent, whether that's mom or dad, I see some correlation with this idea that I'll never be able to succeed at the extent as a parent. And what does that mean? And what does succeed mean? So maybe financially, you might not get to the point where mom or dad has created an empire, but what if you're an amazing parent and you are a great brother and you're a fantastic sponsor or sponsee to other people, or you give back to the community? Is this another version of success? So this is another thing we like to tease out. What has our social, how is our social constructionism been built? And how can we recreate what we identify as a good parent, as a great father, as a man in recovery? What does that mean as a woman in recovery?
Yeah. And I think one of the things I want to add is I want you to really take a look at the word language, because it's also, we have to model this new language for our patients and clients. And what I'm going to say to you is that I stopped talking to clients and families about problems and issues, and I started talking to them about challenges and opportunities. Because we have to change the landscape. Remember, I told you I wanted you to look at language and landscape as we go through this with family systems. If we're doing nothing but talking about problems. And now I told you I've been in this industry for 30 years, and the family disease is a very negative connotation. Very negative. I mean, if you think you have your family's diseased, I don't know how willing you are going to be to sit down with me and talk about that disease. But if you see your family system as having things that have impacted it, that things that have fears, that there's going to be these challenges that we need to look at, these new opportunities for growth, that changes the whole definition of how we start to perceive ourselves, even as family members. Got to remember, perception is 99.9% reality. So if the family perceives themselves as a loser parent, they are a loser parent. Those behaviors are going to infiltrate into that family system. So that's why I want people to really think about the language you use with these families, because if we're doing nothing but talking about problems and issues, we are feeding into what's called crisis-centered behavior. And what we want to do is get this family out of the chaos. We want to remove them from the chaos, and we want to be able to get them to see the light at the end of the tunnel.
I'm so grateful to hear Dan speak on this. I know from when I was studying postmodern systemic family therapy, I genuinely gravitated towards a couple theories of practice or theories of thought, if you will. And one of them was narrative therapy. But what Dan just described kind of verbatim is this idea of narrative therapy, where we externalize the problem conversation. Specifically, as you'll see in this slide, we change the way clients and their family members view themselves and their loved one, and assist them in reauthoring their story in a positive light. I met with somebody yesterday who was once extremely successful, a medical professional, had a physical ailment or an accident which shifted their life significantly, became med dependent, and then gradually became extremely depressed and identified as someone with chronic pain, and to this point where they have now determined that, is life even worth living because I'm not this and I'm not that. I'm no longer practicing this and I'm no longer doing this. So as this gentleman was stating, and he continued to look at me like I was nuts, but as he was stating, I'm no longer a physician and I'm no longer a great dad and I'm no longer this, I would speak on top of him and say, you are a great friend. You are healthy in thought. You are, you do have the opportunity to relocate and to rebuild. And as I was doing this, as he had this negative kind of narrative, if you will, this idea or the story about himself, I continued to interrupt him. And he says, you continue to interrupt me. And I said, thank you for noticing that. Do you hear the words that I'm using? And do you hear the words you're using to describe who you are? And he stopped and got a little tearful. And he said, do you really see me like that? And I said, absolutely. Majority of your life sees you like that, but you're stuck. So the idea that people get that we tend to treat, if we get to treat them, right? If we have the opportunity and that one kind of window of opportunity to treat people who have very negative self-talk going on, that might think, what, I can't cope anymore. I don't want to live anymore. What an opportunity we have as clinicians and case managers and people that refer people to treatment facilities. We can be the one to get somebody in front of somebody that cuts them off and says, you know what, you are not the things that you tell me that you are. You are actually something completely different. And my job today is actually to wipe the windshields and for you to see a completely different identity for who you are. And let's get your family on board. So your dad treated you this way and your mom treated you this way and your wife left you and walked out for another man or woman. That's okay too. That's old news. Let's create a new story. Tell me about the relationship you intend to walk towards. What can you offer that person? What are the qualities that you demand or that you feel you deserve in the next relationship or the next marriage? So thank you, Dan. Talking differently about the problems, right? What am I walking away from? Oftentimes I present invitations to clients when I meet with them that allow them to think in between sessions about who they are, their perception of self. My favorite 3 questions are, who are you? They look at me like I'm nuts. And I say, thank you. We could play with Dan. Who is Dan? I don't know who I am. I've been drinking and using drugs and hurting myself for XYZ. Who would you like to become? And how will you know when you've become him? Indicating that my language is stating that you are on your journey, you're on your way to becoming him. Who is it that you wish to become? And most importantly, who are the characters in your life that you wish to take with you as you're moving towards this new person that you're creating, right? Your perception of self is shifting in a positive fashion. Who are the people you are inviting, right? You have control over those that you choose to take with you. And then the other questions that I really, really enjoy asking as it pertains to a system, what 10 qualities I deserve in a healthy dynamic, a healthy relationship, a healthy system, not necessarily a romantic relationship, because we are not as motivated to discuss those things in early recovery because we're trying to rebuild the relationship with self. But who and what am I walking away from in my life? Who are the people? Who are the ideas? What is the narrative that I choose to walk away from? I'm not a loser. I'm not a bad father. I am not, rotten, or my life is not over because I can no longer practice medicine and practice law. Now I have an opportunity to do new things. And most importantly, because that's looking backwards, what am I walking towards? And then we're generating or we're planting the seed where now we're solution oriented. As Dan's been mentioning, the intention for changing language. What am I walking towards? Who am I taking with me? Who am I inviting into my life? If mom and dad have been abusive with their words and their messages, perhaps I'm no longer taking those labels and names with me. And mom and dad, you want to be invited into my recovery life and my new life, or you want to have a place in my new life, boyfriend, girlfriend, husband, wife. These are the things that I require for me to maintain my mental health and my recovery. Get on board with me. Let's work together. Okay, so how is the family responding to change? I've always found this fascinating in the past when contacting families and saying, wow, Johnny is one awesome individual. He is incredibly motivated. And wife or loved one says, Johnny who? You must not be talking about my husband. And I say to them, actually, I am. The version of Johnny I've seen is someone who's motivated, extremely transparent, authentic, breaking down in every group, eager and desperate to get better. So how does the family, who oftentimes is extremely resentful, angry, agitated, cursing the patient or loved one out while they're trying to get better, how can family shift gears to acknowledge a different theme, right? A theme where Johnny is now a rock star and a leader in the groups and is sharing a lot of information and is providing a role model role for other people in the groups. So for example, therapist says, I say, Dan says, your son's becoming a loyal man in his recovery. Family says, oh, really? He's no longer a lying thief. He hasn't, who's hurt his entire family. He's no longer cheating on people. He hasn't robbed anyone there yet. How does identified patient respond to both remarks, right? So there's this solution-oriented perception of person who views me as a good person. Meanwhile, I know what I've done over the past 5, 10, 15 years. I know that I just robbed my family. I know that I've been pawning their jewelry. I know I've been doing all these things. And that was and is a part of me, but I'm also now recreating a new perception of who I am. I am not only the person that's created all this problem, but I am walking towards a different perception of self. And hey, family, please help me. Hey guys, let's please get on board for this new person that is no longer the person that's done all those things. I will work through them as I work my recovery, but family, I need you on board with supporting this vision, this perception of self that is not all the bad things that I once did, right? I am not those behaviors. I am a person who's eagerly trying to get better. And family, I need you as my immune system to be healthy and not live in resentment.
So I want you to think about something, because I use 2 words with family systems that are going through what Amy is describing to you. I use the word connected and disconnected. In the family that's disconnected, the other kind of quote that I use with families is, I need you to move out of the identified patient syndrome. Because one of the things that happens to the identified patient, if we don't address it, is that they are always going to be the identified patient. They are always going to be seen through that lens. And one of the biggest things that happens is that false expectations are created from looking at that identified patient through that lens. A lot of times in 30 years of doing this, I have families who will say, is Johnny fixed yet? And I inform them that I'm not a veterinarian, that I can't fix or spay or neuter anybody. The hardest part about this whole idea of fixing is that we have these false expectations that feed the family system, and that keeps them disconnected. And the more they're disconnected and the more they see Johnny as that awful person, as that identified patient, we're never going to be able to get to a healing space or place. And I need them to start to understand that if Johnny does his self-care and they do theirs, that this family system can get connected. And that's where we want to talk about disconnection and connection. And the way to get the families to start looking at their son or daughter, their husband or wife back being the individual, is to start addressing the identified patient syndrome from the day that they walk through the door. Because everybody wants Johnny to get the help, but they also have, like Amy has described, that anger and underlying resentment that is blinding them to getting reconnected.
So I think we touched on a little bit about rules, how systems have rules for operating, and sometimes those rules don't make sense, right? Perhaps they've made sense in the past, as one was becoming a young man and growing from adolescence to adulthood. But sometimes the rules, especially in relationships and significant relationships, the rules in which the couple has operated are just not productive for either party's well-being. So if we were to tease that out and look with a spouse and a client that might be sitting in front of us, what are some of the rules that have been working and what are some of the rules that haven't been working within this relational system? Being mindful that we're all products of systems, whatever those systems are, And sometimes the family is the smallest system that we're a part of. Other times, systems as large as, let's say, the 12-step program, or the expectations we place on ourselves, or sometimes gender, race, or orientation. It's important to be mindful of the expectations we tell ourselves, right? So if our thoughts are our reality and our expectation is that we have to do XYZ to be a good husband, or else I'm not a good husband, or I'm not a good wife, or I'm not a good girlfriend, perhaps we take a look at the things that we've been telling ourselves that we have to be in order to be XYZ. I think that's really important for family. Does family really understand what recovery means? Does family understand what sober means? So I know there are certain situations where a family might have an understanding of what chronic pain looks like, or a family might have an understanding of what depression looks like. How do we define trauma, right? If family member knows that there's been some trauma in a loved one's life, and they know that they need to hurry up and address it and go to treatment and get fixed, they clearly don't understand the severity and maybe the depth of what that trauma might look like, and the effects or the impacts it might have on one's life, and the relationships in their life, and how they act on a day-to-day basis. So how do we educate and process with family members what specific things look like? I know at Futures, we spend a lot of time with families, whether it be during individual sessions or family sessions. And now Dan has created an entire family weekend or workshop, and his team has created a family workshop and weekend for families to come in and really dive in and talk about what their expectations are, what the problems they're facing are, and it really becomes more individualized. I'm hoping that over time, I know a lot of facilities state that they offer family workshops and family programs, that the family is really being incorporated, because it's so critical in the sustainability of the work that's being done as we're meeting with people. Just as when we meet with people individually, I know there are a lot of private practitioners that are a part of this right now, or as clinicians that practice mental health, as we're assisting somebody that whopping 1 or 2 hours a week, what is happening outside of that session that's either promoting the work and kind of taking care of the seeds that we've planted, or what is going against it? So if you're in a very toxic relationship, whether it be with family or with an employer or with a partner, what does that look like after therapy? Are they threatened by the fact that the person's in therapy? And if so, are they threatened by the person getting better, looking better, feeling better, sounding better in mind, body, and spirit? I know oftentimes we see husbands, wives come to treatment, and then the other partner becomes extremely resentful. What are you doing there? You keep talking about working out and losing weight, and now you're speaking about what I need to do. How do we incorporate the family to be an equal player in this idea of recovery for the system, so there isn't that finger pointing? Okay, so knowing the rules, how do we create the rules? What are the rules? How do we generate something that makes sense for all parties? Which rules within the family system, marital system, or relational system must change after treatment? How do I know if I'm enabling my loved one, which I know that's a buzzword and a word that's kind of becoming slightly more outdated. Dan can speak on that. And how do I know the difference between hurting and helping?
I think one of the reasons that enabling has been a key word all of these years in treatment is that it's just one of those catchphrases, and people really don't know what supporting recovery looks like. So one of the things that we talk to families about is recovery is a process of building new resources and relationships. And one of the things here at Futures is that when we're talking to families within the family forums that we're doing, we're working with all 4 programs. So a lot of times our mental health parents or loved ones that are coming in for the family forums are asking us, my loved one's not a substance use person. What are our expectations going to be? And I think, we have to really look at what the resources and relationships they're going to need to develop for their healthy network. And what I talk to them about is building a healthy family portfolio, about spider webbing and building a bigger network of support and resources. Because whether your person is dealing with bipolar or dealing with schizoaffective disorder, whatever the issue is, we want to learn about it, but we don't want to have them live to the label. And that's one of the things I've put out recently in family recovery is a lot of times is families will harp on a label. They will harp on a diagnosis. Johnny is bipolar with these tendencies, and they will harp on that. And what they're where they twist that is they want a special magic pill. So they'll ask us, you know, what is Johnny on the right medication? Is he getting the right therapy? And they're looking for that silver bullet. And the hardest part about talking to the family about enabling or any other behavior is to support the recovery. The recovery is about a process of living. It's not just a process of getting well. It's a process of living and living a better life. So in that process of living, what are going to be the new resources and the new relationships? And then knowing the difference between resources in the past that have been hurtful and not helpful, and now new resources that will be ones that will support, empower, and be more helpful.
So in identifying systems that individuals are a part of, I'm often interested in knowing a little bit more about all areas, specifically as it pertains to it. The track that I work with at Futures of the Palm Beaches is called Orenda, and it's an executive program. And so what we all know about addiction and mental health is that often people don't change until they run into some level of consequences. And oftentimes when people are extremely successful in certain areas, as I mentioned, they don't necessarily make changes unless something pretty significant has happened. And so I'm curious oftentimes about the marital system, the relational system, maybe with friends, with somebody that one works with or invests money with. Has your economic system been impacted or affected? And sometimes that has not been impacted at all, but what has been impacted? Tell me a little bit about your morals. Tell me about your religious system. What is your cultural system? So another thing that I'm noticing, and another topic I'm extremely passionate about, is cross-cultural education. And just this idea that as we're discussing systems and the systems that we're a part of, that the individuals that are treating the people that come to see us for change are mindful and well educated and understanding of the cultural systems that people are a part of. So if we have somebody that comes in from a Native American tribe, or let's say somebody's Orthodox, or let's say somebody is part of a cult, what is our level of comfort as a clinician in asking very pointed questions to better understand certain rituals, certain ways of thinking? What are the remedies for depression, or what are the remedies for recovery in your culture, in your clan, in your overall group of people? What is familiar to you? What is unfamiliar to you? Even the way different people choose to do recovery might be different based on where they're from or the group that they're a part of. What does their nuclear family look like? So oftentimes we can, just because we're human, we can assume certain things without knowing very much. And a nuclear family, we might find out later in time that they might be someone who has been part of the foster care system, or somebody who is adopted. And what does that mean? And how do we not remain judgmental or have any assumptions about that? Perhaps I had the best life and I was adopted at age 8. Unless we're asking pointed questions, we really don't know this stuff about the family system. Also, what does education mean to the family? Does education mean very little to the family? What does recovery mean to the family? And again, I don't know why, it looks like a typo, but I have economic again. How does that play into the larger system? Is that important? Is that not important? So these are some of the things I think we need to remain mindful of. I feel strongly clients need their families to understand and support the recovery, not as much their addiction. So we get a lot of spouses and parents oftentimes really pushing to get specific details. Well, what were they using? How were they using? How often were they using? How much did they tell you they were paying for their use? Is that information valuable? Sure, it serves some purpose. What is the intention with that information, right? Are we going to use it to weaponize the person that's there? Or are we going to use it so we have a full understanding as to how significant or severe the problem was And we're going to focus on what's really important, what we have control over today, which is not history. We don't have control over history. What is the role of the family in client success? Now, what happens when families are dysfunctional? Perhaps they're actively using, or perhaps they're not taking good care of themselves. What is the role and what are the boundaries that need to be created with those family members for a loved one to really live their best life and their best self? I know I've spoken to many people who have told me they don't wish to become a widow as their loved one is in treatment. Perhaps the history has been that they've overdosed several times, that they're into high risk behaviors in an effort to gain their drugs of choice or their alcohol of choice. What does that mean for that loved one who says they don't wish to be a widow, they don't want to be in harm's way, they don't want drugs in their home? What are the boundaries that they need to create? And how is it that we're going to share that information with loved one who's in the mindset of getting better? So we just need to constantly remind ourselves that there's a very thin line between helping and harming, and what is the family's role in their recovery, not in their addiction.
Right, and I think one of the things that we try to get families to look at is that we're not here to shame and blame them. We're not here to say that what you were doing that was harming or sometimes helpful was the best thing to do, but we're looking for the family to understand that being transparent means that we're going to be moving towards the third H, which is healing. And how are we going to heal? And what certain expectations and boundaries need to change? And this is the biggest thing about families coming to an understanding that recovery is a process. And a lot of times is the magical thinking that happens when an identified patient comes to treatment is, okay, we're arresting the problem, he's going to treatment, he's going to come out well. And so what I say to families all the time, that the mantra in my own life is, do I want to be right or do I want to be well? And a lot of times families just want to be right. And wellness has to be something that's talked about. How are we going to get to a healing space and place? And what does wellness look like? A lot of times I'll ask families, in your family system, tell me about good times. Tell me about the times that everybody was, quote unquote, happy. What did that look like? How did those behaviors manifest? How did things move forward or progress? Because we want to be strength-based, and how we can get them back to looking at, yes, this family can heal is by giving them glimpses back that this family does operate well within these confines or this type of system. So you start to look at, Amy was talking about all the different diversity that we deal with here, our wonderful Native American families. So we know right away with the Native American families is that it's not just the family that we're going to have to deal with on certain levels. It might actually be other tribal members. So that expands the family dynamic and the role within the helping and harming even more. So what we want to look at and explore is having the family system look at who are all the players in this family system. We have multiple cultures here that we deal with here in South Florida, multiple different cultural differences where the family system is not just the nuclear family. So we want to look at who can be a healing member of this family system.
I know I touched on initially about the windshields in which we choose to perceive our reality. I often share this with family members and with clients individually. How is family influence showing up in clients' past perception of self, right? So if we're to look backwards, which I don't necessarily love doing, but I think it's important information that we have a look or we examine that. How does family influence show up in clients' past perception of self? What is a good kid? What is a good sister? What is a success? What are good grades? What does that mean? As we wipe the windshield of past perceptions of self, what is the contribution of loved ones' epistemology, right? The study behind the way we create our reality. So this is getting a little bit deeper, but I genuinely think about if we're going to talk about the family system and the way people perceive themselves, and this idea that great person uses life-threatening coping skill to deal with whatever's underlying, what is it that has created such a significant mindset that they're willing to put poison into their system on an ongoing basis and remain emotionally and physically numb. So for what are those messages? What are those realities or beliefs that that person understands of the world and of themselves? And how do we get in there and do some work with the help of the family system, allowing that loved one or person to be able to see themselves or recreate their perception of self and their role in this world? What is their purpose? Which is another thing I love asking people and families. What is the purpose of you being a part of this treatment? Especially asking a very angry spouse, for what reason do you do this? Why do you stay? Why haven't you left yet? What are you willing to do to see this person get better? What are you willing to accept? What are you unwilling to accept? So just again, being very mindful of this very foggy windshield or perception of someone's life or someone's partner or someone's kid or parent. What are we willing to give up, if you will, to see this person do better? And or am I unwilling to give up any more of self, any more of finances, any more of my emotional health, my sleep, my well-being? What am I willing to do to assist this person in seeing a different perception of self?
This gets into my favorite part of family work. I'm a family of origin guy. I like looking at the past perceptions because you're looking at the foundation in which some of these core beliefs were established. And that's what I want you to think about when we're looking at these family systems. A lot of these core beliefs have been established for multiple generations. They've had these belief systems in place. You know, jokingly said to a client the other day that I turned 55 years young last Friday, and I grew up in a system where cocktail hour existed. It was at 5 o'clock, New England high tea time, as we used to joke, living in Massachusetts. This kind of idea, this kind of cultural belief systems, these belief systems are core beliefs. So when we get families into family forums, we're asking them, give me 3 primary core beliefs that you believe your family system has as a foundation. So you can start to look at those foundations and start to get a better understanding of how this family system operates. You know, as Amy spoke about, you know, some families have these things that they believe are levels of the highest importance. Some of us grew up in family systems where education wasn't important, or certain things weren't important. Maybe religious beliefs weren't important, or maybe they were very important. What we have to start looking at out that windshield is where some of these core beliefs came from and start exploring those core beliefs.
Generational patterns, I think we just spoke about this. Toxic relationship, enmeshed relationships. I know that we have done some fascinating things recently with seeing a system that appears to be dysfunctional, and not only having one individual in the system suffering from alcoholism or substance dependence, but considering the possibility of treating both parties of a system simultaneously, whether that mean one's in detox and one's in treatment, or one's in treatment here and one's in treatment in a different track. But how do we make sure that, as we started at the beginning of this presentation, we talked about the immune system. In an effort to create a healthy immune system, how do we make sure that all parties in that system, when they return home from treatment, are in better shape than they were when someone arrived? So looking at what are those relationships that are actively available to them when they leave treatment. If wife, husband, mom, dad, cousin, sister, family member, when you return home, is going to be actively using, how do we treat the entire system while we have someone with us? So these are some themes to be mindful of. Toxic relationships, we could dive in and explore why things are the way they are. And if things weren't the way they were when someone arrived, what does that look like? How do we paint that picture? What's the narrative or the story in which we choose to live our lives together? Does this relationship make sense? Does this relationship make sense if we're both healthy? And if we're both healthy, what's going to change? If not, as we all know, if nothing changes, nothing changes. But what if something does change? Does that mean that all parties in that system need to change? In my experience, change has to occur systemically. So these are some of the beliefs that we're talking to families about as we're speaking with them especially in the first couple of conversations when we hear a lot of anger and resentment kind of surface. We want to be mindful that this is a process that they're going to play a part in, and not everybody's willing.
Years ago, I worked for a wonderful family director who used to write 2 words on the board during a family forum. He would write the word delusion on one side of the board and he would write the word belief on the other. And he would ask you to tell them what the difference was. And this is the thing, so when we're talking about perceptions and you look at this slide and it says, what is marriage? What is parenting? What define those things? Everyone has a different definition, and it doesn't mean that their definition is wrong. What it is, it's not about right or wrong, it's about right or well. So how do we get to a more of a wellness perspective? And that's the thing, is that's why we really want to look at a family's core beliefs. Because, I've watched so many people walk out of treatment and I say, well, Johnny was addicted to opiates. He can have a few beers, right? So you start looking at the differences in belief systems and you start to think about, okay, what belief systems do we really need to take a look at and reevaluate? And are they helpful or harmful? And start moving forward to that. Some of these beliefs that we thought were beliefs were toxic ones. And how do we change the dialogue? How do we change the tape?
So something I get very excited about that I don't think all clinicians are doing upon admission or first visit is that I really appreciate family genograms or family mapping. When speaking with someone, even if they come to see me individually and it has nothing to do with family work, I'm always extremely mindful and ask questions that fit into this kind of family genogram. And for me, visually, it's very helpful to have the circles and the squares and the lines with the intention of understanding what are some of the patterns in this person's life or in this person's existence or thoughts that might be helpful and which patterns are unhelpful. And so I know if we were doing a little polling, or maybe we could talk about this at the end when we open up for Q&A, I'd be curious to see if there are some people on here that have used family genograms in their practice with people, and if they find that there's some level of satisfaction learning about patterns that exist over time and intergenerational, and see how that plays a part in somebody's current problem set or identified problem set. I just find it extremely helpful to have this visual map, if you will, of the patterns, the relationships, how this person did marriage, how this person might have had what one might consider a broken family or a different type of family, what types of abuse or incest might have existed in one's nuclear family, which created maybe an adult child who chose never to get married or who chose to have different, sexual behaviors or different addictions or compulsive behaviors. But I think it provides a lot of really important information when we break down the individual into a family genogram upon initial meeting. So why or why not? Does it not assist you in building a better understanding of the lens your client operates from? Again, a lot of this talk is about perspective and the lens and the windshield that we look through, and what really creates the ingredients for, we could call it the glass that is built in front of the person that they're looking out of. What filters have been placed in front of them that creates that perception? And how can we recreate the filter so that it's helpful and not enabling and not abusive and not debilitating for that person to be able to live a life that's worth living on their terms, whatever that means to them. Okay, so I think I mentioned one of my favorite, I call them invitations, other people call them writing assignments, that I offer clients is when I first meet with them, I ask them, who are you, Jessica? And Jessica says, what do you mean, who am I? Who are you? And so oftentimes in treatment centers, people who come with a history of substance dependence or alcoholism or depression might have very, very negative labels that they perceive themselves as, whether their ex called them this or their parent called them this, or they just think this about themselves, or the criminal system or the legal system has called them this. I hear junkie, loser, garbage pail, fraud, total letdown, you name it, bad husband, bad father, which really generates a lot of curiosity on my end. This conversation came up yesterday with the same gentleman who's beating himself up for having chronic pain and not really seeing purpose or reason for living. And he identified as being a bad father. So I said, please help me understand a little bit more about how you've arrived at becoming a bad father. He says, well, I've never taken my kid on a roller coaster, and I've never taken my kid on a river rafting trip. And I said, wow. So in your mind, your perception is, in an effort to be a good father, building computers together with your son, who you tell me is into computer science, and generating businesses and teaching them how to invest in the stock market. Are those not good father qualities? And he looked at me again like, well, I don't know. My father took me on a roller coaster, and I can never do that because of my back pain. So what does that say about you? Does that mean that good fathers take their sons on roller coasters? And I think it kind of broke his very focused linear thinking that if I were a better father, I'd be able to do these action-packed activities or events, at which point we were able to tease through that and recognize that he's been a great father, not even a good father, in several different areas, and that does not create a bad father if you cannot do those two events. And what other things can we do in the future that would indicate that you're a good father? Well, why don't we ask your son what a good father looks like, or if he feels that you're a good father, and if you could become a better father, what would you have to do? Something tells me it would not include roller coasters and river rafting trips, but it might. So I think that would be informative and good information. But again, the question is, who are you? Who would you like to become? How will you know when you've become him? What signs will indicate that you've changed? I know we've spoken a lot about diversity, what that looks like in the family system. We spoke a little bit about various Native American tribes, different religions. Even when people identify with a specific diagnosis, my son has bipolar disorder. Yes, ma'am, he does. What does that mean about you? I don't know. Moms might have specific thoughts in their minds that if I did something differently, my son, daughter, loved one, husband, boyfriend, girlfriend would not have this disorder, this dependence, this abuse problem. Not necessarily, right? So we need to be mindful of obviously our curiosity. What are the different things that indicate, that someone is a specific type of person? What's required to be an effective therapist when working with a family that seems unfamiliar? Stay curious, ask questions. People actually, I find, love speaking about themselves. And the moment you ask a question where you've just crossed the line, they're not shy in sharing with you. I did have that happen when asking about the rituals around family members passing as it pertains to, again, a Native American tribe. When you overstep your boundaries, people are going to be very clear and share, you know what, we really don't talk about that outside of the tribe. Well, thank you so much for sharing that with me. That really helps me to support you, because now I know that there are certain things that I should not be asking. What is your willingness to establish rapport with this type of client? I remember very early on in my career, I had a client come in who was released from a very lengthy sentence in prison and had what I consider to be like white supremacy tattoos and some tears from their eye. And being in my earlier mid-20s, I thought I knew what these things meant to them. But until I asked, please help me understand, what does that mean that's on your arm, or what do those tears mean? They meant nothing like what I thought. And they had very little understanding or education about what that means to other people when they opted to do this at 17 or 18 in the location of the country they were from. They didn't know what it meant. They didn't know it would offend people necessarily. And even the tears coming from their eye meant something completely different than my understanding of what that meant. So I think that as we're experiencing some level of some sort of space between yourself as a human being and a healer and the person that you serve, that you're treating, to find a better life for themselves, it's really helpful to create that understanding in the client therapist or the client counselor relationship, asking them what these things mean to them. How does that impact you? Even things that might potentially be offensive to the person helping. What does it mean to them? We might be completely off. And I really like that about systemic family work, is that we can ask these questions, and that once you've built rapport with somebody, you can kind of push a little bit further and learn a lot about what is and what isn't for them.
I grew up with a math teacher. My father was a math teacher, so I look for denominators. I look for things in family work that are common denominators. I call it the human factor. So I start to look for these factors within families, and I know no matter how diverse the family system is, there's one thing that is a common thread. And that common thread is the crisis-centered behavior that the family engages in when there is problematic use or mental health issues or problematic behavior. I think one of the biggest things that when you look at a family system is, what kind of chaos is going on in this family system? What kind of chaotic belief systems are in place? What kind of crisis-centered thinking is going on? And how can we explore in having a true family conversation, how we can get through transparency and tolerance to start talking about this crisis-centered behavior? Because we all have talked for years in family work with substance use disorder or mental health that the family is used to chaos. They become very accustomed to chaos. So when chaos is not there, their homeostasis is, I'm used to chaos. How am I going to get back to what's going on? How do I get away from this chaotic behavior? And I think one of the things that we try to do with families is have them talk to, how does this crisis-centered behavior manifest itself within your family? What does it look like? What are the things that you're dealing with that, are stressing you out? I have wives and moms and fathers that will call me every day and say, I'm still just so worried about Johnny and he's in treatment right now. And it's just, they can't get out of that crisis-centered thinking. And this is why one of the things that we want to work on is actually in diversity is speaking to the family in a language they can understand. And I'm going to repeat that again. Speaking to the family in a language we understand. I do not speak in psychobabble. And that's one of the things sometimes in our field that is stressful to families is that we start throwing things at them because we've been in the field for so many years that we understand, but they might have no comprehension of, well, I just found out from the psychiatrist he was diagnosed with this, and explaining what that means and explaining what behaviors and taking a look at what that looks like through their lens and what fears that they're dealing with in this. And that's the biggest thing about working with diverse families is asking them what they truly understand and what they don't understand. A lot of these families will tell you a lot, especially with our opiate addicted people. They'll say, oh, I know everything there is to know about opiates. Okay, so do you understand what the process is going to be in regards to them detoxing or healing? And when you start to explain that to them, they realize maybe there's a little bit more to learn. So the biggest thing that I think sometimes we miss out on is during that assessment process, when we're doing those genograms, when we're sitting down and doing those assessments, is taking the time and opportunity to educate them on some of the things that they don't understand. So there isn't misinformation going back and forth, because we want them to get out of the crisis-centered behavior. And the only way that we're going to be able to have them do that is to educate them on, okay, what are the things that are still bothering you and how can I give you resources that will help you move forward?
So this kind of speaks a little bit about the topic I had just spoken about in terms of cultural and cultural sensitivity and diversity. Which of these families would you be least comfortable working with and why primarily? So it gives a couple of examples of various people I've worked with: sex offenders who openly share their desire for 10-year-old males, Nazis that have tattoos of teardrops from their eyes, transgenders in the process of noticeable surgery, maybe who's very open about speaking about this, females serving years in prison for first-degree murder of their own child, amputees missing both arms, 21-year-olds currently living with AIDS and openly discusses this. So the reason I bring up these examples is simply because as a healer and clinician, the intention is to get to a place where we are comfortable working with and treating anybody and everybody, because that's really why most people got into this field, is because they care about people and want to see people get better. And I know with the high risk population of substance dependence and mental health and co-occurring disorder population, we see a lot of variety, a lot of diversity in who we're treating. And in my experience, the less I have in common with someone, the more zoned in I am on staying curious and really kind of learning from that experience. So just something to be mindful of as we're talking about family systems and some of the diversity that comes within the family system. If we were to feel some level of discomfort about working with a specific population, regardless of what someone might have done, an action, a behavior, a sexual behavior, maybe a non-forgivable behavior in someone's perspective, we are humans treating other humans, and our intention and our goal as therapists, counselors, clinicians, case managers, marketing people is to help people get better. Especially if you find that this person's done something so horrific, we do not wish for them to reoffend somebody else. So think about as we're working with families and people that might be difficult, or some people might have strong judgments about people who have some of this stuff below. How can we assist people in getting better so that this problem does not continue, if it is a problem? Externalizing the problem and blame. This is kind of what Dan was pointing towards at the very beginning. This is a narrative therapy practice, which is a postmodern systemic family therapy theory. Narrative therapy talks a little bit about relationships and externalizing the problem. Specifically, I ask people who have had histories with substance dependence if they can use their drug of choice, if they can change the name of their drug of choice. In this case, I've asked the client to call their past, let's call it love of choice, or their affair, if you will, with heroin. We've named it Haley. And I'm asking this individual to please compare their relationship with Haley to their relationship with Jessica, who's actually their girlfriend. And wow, do a lot of similarities come up, right? The way this presents as someone is substance dependent is that they've been having an affair behind their girlfriends, and that this drug of choice has become priority and number one to their current relationships and their family members. Have you snuck around with Haley? Again, Haley represents heroin. Have you lied about being with Haley? Have you spent money on Haley behind Jessica's back? How much has she cost you over the past year? Has she ever come between you and your parents, you and your relationships? How has she affected your health? Has she ever put you in jail? Have the police ever been part of your life because of your relationship with Haley? For what reason should Jessica sit back while you continue to prioritize Haley in your life? Oh, Haley pushed you into the ER, to the ICU, you overdosed because of Haley. Which relationship do you prefer? Because Jessica is no longer willing to accept this. Jessica wants to be the priority. Do you wish to have your girlfriend, your mom, your dad, your family member, or do you wish to continue to invite Haley into your life to continue to ruin further various core areas of functioning in your life? So ultimately, why do you keep going back to Haley? And these types of comparisons sound very silly as I'm presenting it, but they're extremely effective when working with people who say, oh, wow, I did have a relationship with this substance that's pretty much life-threatening. She's done nothing for me. She's harmed me. She's cost me this much money. She gave me hepatitis C. I got a DUI. I hurt somebody. I had a physical altercation. My family cut me off. I lost my job. Well, the relationship, and that's what we're going back to, the relationship with Haley. And now there's a shift in finger pointing, if you will. Now family no longer sees person as problem, but the relationship with Haley. Now Haley, or heroin, or the drug of choice, or the drink of choice becomes the problem. So it's a really neat method of madness that I like to do with clients and family members. So we can externalize that client Joe is the problem, and now Haley is really the problem, or the relationship Joe has created with Haley. It's not Joe. Joe's a good person living with a life-threatening disease, and the relationship with Haley creates Joe's problems, if you will.
What this exercise is good for doing is looking at those two things I told you in the very beginning, is to look at language and landscape. Amy's been pretty good with this slide and talking about Haley being heroin, and I can't do that. I'm a former Marine, and in the Marine boot camp, they used to talk about Jody. And the problem is I married Jody. My wife's name is Jody. So I can't, but I use language to look at what's going on. So to give you an example, just recently, I had a couple that came in for the forum. They have been doing this kind of narrative work with Amy. And when they when they got into a session in the forum, the word betrayal came out. And in the relationship, they basically saw the wife, who is the family member with the husband, who was the identified patient, saw his relationship with alcohol as a betrayal. And they're to the point of an emotional affair, and described it as such. And there was this process of looking at trust and what that represented for her, and how this betrayal had played out over the years. So, you know, renaming this or looking at the language that a family uses is extremely important, because it brings them into their landscape or their environment. When we talk about the hidden resentment, those are one of the biggest things that happen within a family system, is the fear and underlying resentment a lot of times are not talked about because they're sore spots. And those sore spots are things that we're going to have to talk about. Okay, I need you to kind of tell me what this is for you. Tell me, using your language, what this represents for you. And that when that word betrayal came out, that's where we had to start. And that's why I like doing this kind of narrative stuff, is to look at the words that family members are using so that we don't get into the finger pointing and shame and blame game.
Okay, so the blame game is just that. We wish to blame the addiction, not the person. And if we externalize it and make heroin Haley, and certainly for certain people that are watching this, if substance dependence is not really your specialty, we could, you know, we can interchange the word heroin to anything. It can be alcohol, it can be depression, it could be sex addiction, it could be overspending, it could be anger. So we wish to blame the problem, right? Not the actual person. And then it takes a totally different spin on how we're going to address this. Okay, his fault, her fault, their fault, not me. Okay, so the alcoholic cannot resist subjective, non-judgmental, clear feedback from family. So these are just some ideas about how the family and the loved one can start to externalize the anger or externalize the behavior, so it's not specifically directed at the person, creating more destruction, if you will. Now, I've had people write letters or breakup letters specifically to, let's say, Haley, and the destructive relationship one had with the feeling, emotion, behavior, the drug of choice. That's the doc, the drug of choice, that they are experiencing. And then they can then read that sometimes out loud, sometimes in front of family, sometimes in a group, but talk about how, from their mouth, how that relationship with alcohol, which might be Allison, or their relationship with Andy has affected their marriage, has affected their family, and how they are not willing or unwilling to invite that person, if you will, back into their life, indicating that they've identified that that relationship doesn't serve them.
Exactly. And on the flip side, what we do with the family member, when it's just the family members, is how are they going to say goodbye to the crisis and chaotic behavior? What are the things that they're going to do for their own personal recovery in regards to being in this crisis-centered behavior? What things do they need to work on for their own personal healing so that they can disconnect from this crisis-centered behavior and start moving towards an actual productive and constructive way of dealing with all of the family dynamics and moving towards healing?
Dan basically summed up the next two slides. So what is your new role post-treatment? What is the family's role? So for a very long time, all fingers, all eyes, the spotlight has been on quote unquote alcoholic. They were the primary or the identified patient, and oftentimes exclusively they were the person we were focused on. Now family members have argued, worried, rescued, pled, avoided, supported, and been totally obsessed with their loved one's addiction. What if we no longer have to obsess about this person or this quote unquote sick person's obsession, and they become healthy? What happens to the remainder of the family? So they've fallen into this old role, and now it's time to recreate what those roles look like, which is exciting and fun, but very scary oftentimes for family members.
So here's a phone call I had with a mother just yesterday. Hi, Dan, how's Johnny? How are you? How's Johnny? How are you? How's Johnny? We went on for 5 minutes and she said, "You're not going to tell me how Johnny's doing, are you?" I said, "Absolutely not. We're going to talk about how you're doing and the things that you're working on." Being Dan, the family man, has given me the ability to basically, the patient is the family. I get to work with the family, and the family a lot of times wants to keep the hyper focus on the patient. And this is the new role post-treatment, is how does the family recover?
Again, a lot more blaming, right? In systemic therapy, focus changes dramatically, sometimes for the first time. And the blame is lifted from addicts, sometimes onto the family. Family is now fully exposed and having to make some changes. And this becomes extremely uncomfortable for family. It is time for this family to get help in addressing their fears, their worries, understanding what support should look like, and also focusing on their physical and mental health. So frequently, I have family members tell me that they have high blood pressure, cholesterol issues, et cetera, et cetera. Worst case scenario, strokes, heart attacks. What happens as their loved one is getting healthy? Are they ready to start taking better care of themselves and prioritizing their own mental health and physical health again? And that requires really serious boundary setting. This speaks more of the benefits of the systemic method and why it's so powerful and effective. As we know, these are family diseases, which then means that the solution must fall on the family and that this now becomes a family affair, if you will. The more people in the system that change, the more long lasting the change will be and the more quickly it will be accomplished. That's my belief. Maybe everybody doesn't believe that. And that does not mean that if the loved one does not continue in their recovery process, that the family has failed. This is a process. It's an imperfect process, and the family can only do their best to assist and support in their loved one's journey. But there are no like finite fixing or definitive answers as it pertains to the family system of someone in recovery or working towards better mental health. So that's something to be mindful of.
And that's one of the things that we as practitioners have to really consider, is how do we change the dialogue? How do we basically get families to look at what their identified needs are? And this is where self-care comes in. So we just kicked off family forums at Futures, and the families came in. And of course, what did the families want to talk about? The identified patient. And we spent no time talking about the identified patient with this caveat. We talked about how the impacts impacted the whole family and what do we need to do for family recovery and healing. Because the statistics are out there that, you know, that none of us like to look at, that 10% of people recover. And one of the reasons being is that there isn't a community, and we all know it takes a village. It takes a village. So that as the family recovers, the person that is in active recovery themselves has the ability to do their work. And that's what we said to the families. Do you know that if the family engages in recovery, that gives the identified patient the opportunity to engage in recovery? And looking at the process of now, not the family disease, but the family healing, and now family disease equals family recovery. If the family recovers together, the odds are that the person that has the active addiction or mental health problem will also recover.
This slide speaks a little bit, it's more of the same, that basically once the family gets well or the family gets better, individual is more likely to create healthy boundaries with dysfunctional family members, allowing family members to get healthy and better. Okay. So this is specific to family members as someone is transitioning out of treatment. There are oftentimes recommendations about what they should be doing or should not be doing as their loved one is healing and the family is healing. Oftentimes we suggest limits on money, that money can really be a crutch for people. Understanding our roles, the parent role versus the sponsor role versus the probation role versus the case manager, the family coach, the interventionist. We need to be mindful of everybody's role, and the family needs to understand what that looks like. What are some of the guidelines for aftercare? Oftentimes these things are shared. I know at Futures, we have aftercare planners, we have case managers. They're oftentimes working in conjunction with the people that have been a part of that person's life before coming in, whether it's a sober coach or it's a therapist or a psychiatrist or a doctor or a family member, or maybe that entire team, but we do a great job at collaborating in aftercare and making sure that they're set up for success. My recovery is my recovery. Family should have that mindset. Identified patient or client should have that mindset. Everybody has to work their recovery program. Redefining the roles, super significant in understanding what is my role in this person's recovery. I do not need to call them every night and ask them if they've gone to a meeting. I do not need to ask for their sponsor's phone number and name and address. Completely inappropriate. And most importantly, making sure that we all practice self-care. You want to jump on this?
Yeah, I think the biggest thing that we're talking about is having resources and relationships for everybody. You know, and Al-Anon's famous tagline for years has been, you didn't cause it, you can't cure it, you can't control it. And we remind families that they need to do their work. So families that leave our forums leave with a family treatment plan. And I do mean a family treatment plan, which looks at what does mom need to do? What does dad need to do? What are the new resources and relationships they need to develop? How are they going to build a new recovery network for themselves? I jokingly have said to patients and families for years that I believe in the Verizon network of recovery. Can you hear me now? Because the more cell towers we have in our lives, the easier it is to connect. You know, the one thing that this pandemic did is, if I could see one silver lining, is that it did allow us to connect through these new IT ways of doing things. And now we're able to communicate to a lot of different new resources all over the country, all over the world, and being able to see them in the face and talk to them about our specific issues. So there's all of these resources that we want to explore with families. What are things that, you know, I had families from 7 different states in the other day. So it's like, what resources do I have in my area? What resources have I already explored? What more do I need to look at? So when we start exploring these resources with families, it's not just for the identified patient. We have to get out of the identified patient syndrome and see the family recover. Because as the family recovers, that whole village is going to be able to support the person with the identified problem. I don't know if any of you out there, and I'm sure everyone out there is going to agree with this, kind of comparison. If you've ever caretaked for someone that had a very, hard illness to deal with, whether it was Alzheimer's or cancer or some sort of illness where it took a lot of energy that was expended on your part to be able to support that person. You know how hard it is to be the caretaker. And that's the one thing that I remind myself of every single time a family walks into my office, is that these folks have been caretakers in a very, very hard and stressful time. And they are exhausted. And there is no respite care for a family that's been dealing with a substance use disorder patient or somebody with mental health. One of the biggest things that is why I want people talking about family recovery is to reduce stigma about the whole idea of what recovery is about. Because if we think of recovery as a process of living, not just a process of getting off a substance, recovery is not just about abstinence. Recovery is about living a better life. And that's why I'm trying to get the most information out about family recovery that I possibly can, so that people will reduce the stigma. Everybody in this world right now is recovering from this pandemic, and we're either doing really well or we're still stuck in that crisis-centered behavior. And it's hard not to be. I stopped watching the news at night because I did not want to hear the death toll numbers. I want basically people to look at how we can support the process of living and moving forward, because that's what family recovery is. I have caretake for a father with Alzheimer's. I have a son with severe ulcerative colitis. I know how hard it is to be a parent, a family member, and dealing and trying to caretake for a loved one who is under a lot of pressure due to their malady that they're dealing with. And that's the thing, is that we as family members can support each other. We as clinicians can support each other. in regards to the fact that recovery is a process of living and we need to help the whole family start living. So it's funny, I finished off the family forum on Saturday, this past Saturday, and the first question I asked was, what's one new thing you're going to try in regards to living? And the things that we got as feedback was amazing, because one of the things that happens to us when we become in crisis-centered behavior is we forget to live. And my father had expression for years that there's a difference between living and existing. And now it's time to start looking at what we need to do to live.
Okay, I really appreciate everybody tuning into our slides and this talk. I know at this point, we're very motivated to hear from people who have been listening, and hopefully you have some good questions for us about anything that we presented around family systems, the perceptions, externalizing the problem, the narrative therapy. We're here to take any questions that you guys might have, and hope that you learned something from our presentation, and just thinking about better understanding the frame of reference from which we operate and which we address family members with. And we're just very, very appreciative and grateful that you've tuned in today. I don't know if anybody has any questions for us.
Go ahead, Doug.
Dan and Amy, thank you. That was an outstanding presentation. I especially appreciated the slide about what would make you least comfortable. I think that's great for those of us as clinicians. And Amy, I want to add something about the genogram.
Please.
I love that you do that, but I'll tell you that in outpatient practice, I have for years had the following system: executive overview first session, genogram second session, goals with the client third session. And the reason for the second session with the genogram is because I want to make sure that that individual or couple or family that's coming back in has bought into Therapeutic Alliance and they're showing up at my door the second time, because then I know I can ask those really hard questions related to family history. And one of the things that I love doing with couples is having them compare their genograms and to say, okay, now that your spouse has told me about the family, what's your perspective that what he or she hasn't told me? And it also continues to really deepen the information I get about the genogram. So
Thank you. I love that suggestion.
yeah. So, but again, fantastic presentation. Thank you both.
Thank you so much,
Thank
Doug.
you.
I appreciate your input. Thank you.
Ellen?
Can you hear me now?
And I can.
Thank you,
Okay.
Emma.
I have a speaker in the other room. Give me 1 second to turn off the speaker. Oh, gosh. Sorry, not very technical. Can you hear me okay now?
Sure
Perfect.
can.
Thanks, Ellen.
Ellen Ann Muth here. And Doug, I'm so fascinated. I was going to talk about genograms too. So thank you for the lead-in. I'm just so touched because I believe so much in the genogram. I am a genetic counselor first, and then a social worker second. So just a brief history. I became a genetic counselor in 1977 in a 2-year master's program at SUNY Stony Brook. I was working at a university genetics center, and then I was blessed that the social work department offered me a maternal and child health grant to get a second master's in social work. So I was always taking genograms in the context of social work. But here's a little caveat. It's not easy to learn all the little symbols, and I would recommend perhaps if futures could do a in-service on how to take a genogram, that might be helpful. Because as an example, there's like, how do you set it on the page? You know, depending upon if there was multiple marriages on the one side of the family or the other, because sometimes I would fall off the page if I didn't learn to ask the question, at first, were there multiple remarriages, and which side of the couple. The other thing is, And this is really interesting that having been trained as a genetic counselor first, I always, of course, because genetic counselors do this, we did a deep dive into neonatal loss.
Mm.
And we would make a distinction between miscarriages, stillbirths, elective terminations, right? And other live births. Like, for example, I worked with a young couple, they were both about 30, they had a child with Down syndrome, and they didn't want to take the baby home. So that baby was out for adoption. Couples sometimes wouldn't talk about that because of the shame. And I remember I'd always ask the people if there was a neonatal death, what is your understanding of why the baby died? And I remember one mother said to me, God punished me because I had an abortion. So in other words, God gave me the deformed baby because I was bad by having an elective termination. So, and the challenge is there are so many different symbols, like for multiple marriages, how to set it up on the page.
Yes.
Stillbirth. In other words, there's all this nomenclature. So I think suggesting people should do a genogram is a wonderful idea, but we had hours and hours and hours in training how to take the genogram. So I don't know, Doug, have you found that it's not easy to do? Or how did you learn I'm presuming you're not a genetic counselor, Doug. How did you learn how to take the genogram?
I learned in my master's program too many years ago to name that I'm comfortable with, like Dan. But I took the information with me, and again, it's just allowing the clients to share their perspective and guide with some questions. And again, I agree with your suggestion, Ellen, for futures to have an in-service specifically about genograms with our two experts here. I think they do a phenomenal job.
I really appreciate those.
Yeah, appreciate the
suggestions.
feedback.
That's awesome feedback. And we'll certainly look at it as a system at Futures of the Palm Beaches for future educational purposes. Perhaps we do a lecture on genograms in the future. So thanks for the suggestion, Ellen.
Yes, and one more other thing I can add, there might be some online tutorials perhaps, or some symbols, how to actually notate a death versus a termination. And I found through the years, if I always did it for every patient in the therapy practice, and let's say they came back after 2 years, having the pictorial of the genogram, it allowed me to refresh my memory and see the whole family system right in one page. So it's wonderful on so many levels.
That's right. Thank you, Ellen.
Thank you.
For the sake of time, we have about 9 minutes until the program ends. I just wanted to see if we had any questions about any of the content that we presented. I'm hearing some really awesome ideas, but I want to see if there were any questions specific to the family systems. Certainly the suggestion for genogram sounds like an awesome one. We'll consider that as a system, as a larger system, and see what we can plan for the future. And I love the idea. But anybody have any other questions as it pertains to some of the information Dan and I presented?
Go ahead, Brandon.
Yeah, thanks, guys. And Ellen, one of the things you said kind of prompted this question, so thank you. It was more around like within working with family systems, how can we better prepare and help families move from this irrational fear-based thinking, fear-based behaviors to a more healing, positive mindset? I think that's an important question that I wanted to make sure I asked.
Sure. I think one of the things that we look at, and it was kind of Doug touched on it, is that, I also don't jump right into the genogram first. I call it the first session, I call the family conversation. And in the family conversation, it's just kind of doing almost what I call it framing. You're looking at kind of how the family system, what have been the impacts. And one of the tools that I think that helps us with framing at Futures is the family questionnaire. And we tell the families it's a pretty lengthy questionnaire. It's about 6 pages, and it has a lot more to do with the family than it does the identified patient. So we start to look at kind of what their perspectives and ideas are in and around that. So then I love what Ellen said about, learning how to kind of paint that portrait using all the symbols to do the genogram next. So we kind of start with the family conversation, and we get into looking at what those core beliefs are so that we can see what the fears are, so that we can move them from the irrational crisis-centered behavior to the more rational, okay, what do we need to do to kind of make a more intellect over emotions kind of situation here, where we start to look at, as evidenced by this, I'm going to do the following, and get them into more of a new routine and structure. But it's a great question.
Thank you. And I think Cindy's next. She's got her hand raised as well. So I'll pass it over to Cindy.
Thank you. It was a phenomenal workshop. My question to you is, I also do genograms, and I do them on the first session. And I graduated in '82, so I've been here over 30 years. So the
feel better
question I
now.
have is, since I work with trauma and I work with addiction and I work with dual diagnosis and I private practice, if you look at a cultural moray, and I have a client who was an incest survivor of his stepbrother, and you're doing the genogram, and then you have homophobia in the primary family, you say you want transparency, but I do not think it always is appropriate. And when it comes to the shaming of men with early molestation within the family system, just like you say that you don't want to have to ask questions about the sponsor and all those questions, well, sometimes the toxicity is in the family, but on the edges of the family. So maybe in the future, if you're willing to explore the balance between how do you have transparency when you have these very dark family secrets, when you have cultural mores that do not align with your beautiful theory of what is the healthiest, yet in reality, the toxicity is the monster within. So I've worked 15 years with perpetrators, and I'm also a forensic counselor, and some of the darkness in your family systems will never be told. So
I agree with you. I think when we talk about transparency, we're talking about self-care. And when you're talking about that type of impactful trauma, you know, that is something that you really have to look at in regards to whether being completely transparent with the family system is going to be something you're going to dive right into. And of course, no, it's not. It's going to be them being able to, number one, have the courage to speaking to you about the traumatic impact that that's had, and then helping them be able to start working on the base of the trauma. You know, coming out of the Marine Corps, I have this wonderful thing called PTSD, and looking at the hypervigilance and hyperfocus that comes from dealing with that type of traumatic experience. And that's the individual self-care that particular individual is going to have to do. Because of the cultural mores, would I involve the family in that situation? Absolutely not. You know, it's going to be looking at what do I need for my healing, and who do I need to tell my truth to? That's more the transparency. But that's awesome, Cindy. I really appreciate the question. And I know we got room for like one more, and I see Cher, you can ask your question.
I just have a really quick comment about, I really like that aspect of externalizing the addiction, making the problem be outside the family. I have found that so helpful for family members to get out of that personal, you know, feeling and not let it hold the whole family hostage. So I just wanted to say I really liked your mentioning of that.
Thank you, Cindy.
Thank you.
Great job, Dan and Amy. We're so grateful to have you here today presenting for all of us. Before we close, I just wanted to thank Bayside for co-sponsoring our event today.